All right, guys. Hey, I'm really sorry this is not as timely as I thought it was going to be, but I could not get my Blackboard Collaborate or to record. So after many, many tries and talking with the gal who set it up at Baker tonight, they have got to put in a work order for it. So you're watching Screencast-O-Matic instead for these two chapters. So we're going to go through these. Just make sure that you write down anything that I kind of stress the importance of, and continue to go through these PowerPoints afterwards, and make sure you check out anything in the book that we talk about. All right, so here we go. So diuretics, purposes for diuretics. One purpose is that it can lower blood pressure, and it may be used alone or in combination with something else, and then to decrease edema. So increase urine flow, inhibits sodium and water reabsorption from kidney tubules. So essentially what ends up happening is that many diuretics end up taking the fluid that would typically sit in the extracellular spaces and moving it back into the vascular system, and then the kidneys would end up excreting it. That's why when we give a medication like furosemide, also known as Lasix, that our patients will go to the bathroom like crazy. So, but it also works to lower the blood pressure. So you've got a little diagram here that you can see. It's kind of the setup of the kidneys and everything that's happening, and diuretics that act on different segments of the renal tubes. So you have your thiazide up here that you can see. There it is. Your thiazide diuretics, and then over here you have your osmotics. So we typically work with thiazide diuretics, and then sometimes potassium sparing diuretics depending on the patient's disease process, because our thiazide diuretics actually decrease the potassium. Well, I think we talked about it before in class about how they need to either be encouraged to eat foods high in potassium like bananas or green leafy vegetables, or that we have to put them on some kind of replacements, or they may be put on a potassium sparing, just depending. So again, we're kind of talking about this right now, types of diuretics. Important is going to be your thiazide and thiazide-like, because those are ones that we definitely use a lot. Loop diuretics are something you're going to see a lot, but just be aware you have all these, and then the potassium sparing. So our thiazide and our thiazide-like diuretics, you have your list right here that you'll see. Hydrochlorothiazide is a big one that patients are on for their blood pressure. I see that used a lot. The rest of these, I've seen chlorothiazide used, a couple different ones in here, but I know for sure hydrochlorothiazide and the chlorothiazide will be ones that you would for sure see in the hospital. So these act on the distal convoluted renal tubule. They are used for hypertension and peripheral edema. So you're going to be able to use this for your drug card for some of this stuff on things that they do. If you keep looking down, you will see that they cause a loss of sodium and potassium, magnesium, but they actually promote calcium reabsorption. So you often need to give potassium supplements, as we were talking. Can affect glucose tolerance, causing hyperglycemia. So we use with caution, but doesn't mean we won't use, because again, we may have to look at the risk versus the benefit. And then caution in cancer digoxin, because hypercalcemia is increased. And remember, these patients that are on dig have some big heart thing going on, and calcium affects muscular contraction and different things with our muscles. So we have to be careful with patients that are on dig for their heart, because we don't want to cause them too high of calcium and cause some kind of dysrhythmia. So continued here, you will see all the different things that it can potentially cause so with thiazide. So again, what I just said, so you got your low K, your low magnesium, your low calcium, and then if you look down here at the bottom, you have your hyperglycemia and hyperlipidemia. So just things to be aware of. We're going to continue here. These actually, you can go ahead and use these again if you need to for part of your drug cards as far as the action. So the kinetics, it's well absorbed from GI tract. The half-life is longer than that of the loop diuretics, and you want to always give diuretics in the AM to avoid them peeing all night. That's what nocturia is urination throughout the night. So if a patient comes in and it's not going to cause them a serious issue that we didn't give them their diuretic because they are getting ready to go to bed, that would be a nursing judgment call. Am I going to have this patient up all night peeing, or can I wait until the morning to get them started on the med? Dynamics, they act directly on arterioles to cause vasodilation. So remember, vasodilation, I'm going to open up those veins, which is going to lower the blood pressure. It's going to promote sodium chloride and water excretion. Decrease vascular fluid volume, decreases cardiac output and BP, so again, lowering the blood pressure. Onsets around 2 hours, peak 3 to 6. It can be broken into short, intermediate, long-acting duration. Still staying on these, there's your side effects, so go ahead and use those. You have your contraindications, so renal failure. We'll talk more about that when I see you. But yeah, patients with renal failure, many times we can't give them certain diuretics because we'll actually make them worse. So drug interactions, we just talked about and digoxin is the most serious. And then lithium enhances it, so toxicity, and may potentiate actions of other antihypertensives drugs, which can be an advantage. Okay, so if it's potentiating the action, it's helping with the blood pressure. We would definitely be watching that. That would be assessment data we would be looking for, because we don't want to cause a person to be hypotensive. So loop diuretics, there you're going to see your furosemide, your Lasix. I hope I didn't say that wrong in the beginning. I may have said, I hope I didn't, and I really don't want to start re-recording. If I happen to have said that furosemide was thiazide diuretic, which I don't think I did, but if I did, that's wrong. If I said that, take it out of there, and know that furosemide, aka Lasix, is a loop diuretic. So that's going to be like the most common you're going to see in the hospital. You're also going to have the Bumex. That's also pretty popular as well. Your action is right here, so you can see what your action is for your drug card, or drug cards for the loop diuretics. Going to be an important one to have. So then you can read right through all this stuff right here as you're making your drug cards for this. Loop diuretics should not be prescribed if a thiazide could work. They're more potent, 2 to 3 times more effective in inhibiting reabsorption of sodium, and are less effective as a hypertensive. So that's why they would want to go with a thiazide first, and you're going to see a lot of thiazides. But then you'll see loop diuretics too, especially if you work in an ER or an ICU, because we try to get the extra fluid off them fast. We're never going to combine Lasix and another loop diuretic. We will dry a person out and could potentially kill them. Interactions with digoxin again. So this is going to be important to know that your dig is going to be contraindicated for both your thiazide and loop diuretics, and you may need potassium supplements because these are not potassium sparing. They take the potassium out with the fluid. So laboratory changes, again, it's kind of the same as the other ones, some of them anyway. So you have your low K, your low sodium, your low calcium, low magnesium, low chloride, and then you have this other stuff right here that you can read and include if you'd like to. So you have your kinetics and your dynamics here as well. If you look under your dynamics, IV Lasix onset is 5 minutes. I have literally seen where I've given IV Lasix to a patient, and 10 minutes later, they've already got 500 mLs of urine in their bag, or in their Foley catheter. So it can work really fast for your patient that you give IV Lasix to and you don't get anything. That's not a good sign. Kidneys are probably shutting down. So then you have your side effects down there that you can see, and including your drug cards. So then we have osmotic diuretics, and this is mannitol is a medication that is used typically in a neuro ICU setting because they use it to decrease ICP, which is intracranial pressure, and decrease interocular pressure. So a lot of patients who have been in like a big accident and have a major head injury, and they swell, mannitol will be used to try to bring that down. So I don't see this, like where the ICU that I worked in, I didn't see this used a ton. I did use it sometimes in patients, but it's actually, it's used more so as usually the person's quite sick that's going to be getting this or in danger. But it's still a good one. It's an osmotic diuretic. You have your side effects in there. Very important, and we did talk about this in the lab, but you guys may have forgotten, is that mannitol is one that we have to use filter tubing, not only a filter needle, but filter tubing in order to administer, because the crystallization can potentially happen. So even though here it says if exposed to low temps, even if it is a warm environment, you still have to use that filter tubing. So I'm going to kind of skip through the carbonic and anhydrase inhibitors. I don't see this used a ton. You can review this, but for me, I won't be asking you. So as far as a card for this, you won't need it. For my class, you may need it if you see it in the clinical setting. Potassium-sparing diuretics. This is another one that you will become familiar with. L-dactone, the very first one, or spirolactone, is one that I used quite often when I worked in the ICU. So you're going to see the different things right in here, your action, and then you want to make sure that you're watching their potassium levels, because we can potentially cause them to be hyperkalemic instead of hypo. They are not to take potassium supplements, and we actually end up teaching them many times to restrict their potassium. They don't want to take as much stuff or take in as many foods that have a lot of potassium in them. All right, so I'm going to actually end this now and come back and make a second one for chapter 44, because I don't think I'll get through. I only get 15 minutes on screencast-o-matic. So I'll record a second one for you, but remember, you have to definitely watch both of these because there will be test questions, okay? All right, guys, I'll see you again in a minute.